So we have got Murty, and thanks very much for sorting that out, Murty. I'm delighted that you've got your computer driving test sorted. And
wow.
so,
Well, there you go. There you go. So I keep talking about keeping your head, and I couldn't keep my head when I was doing this.
yeah, no, that's fine. So we're slightly a little short of time. So if you could run through relatively quickly, that would be awesome.
Fantastic. Well, before I start, can I say that I was so proud that I was sharing the podium with all of you guys, including you, Sam, and Matt, that I sacrificed my mustache that's on the photograph. Anyway, so some dull bits. By 2050, we will have 6.26 million hip fractures per year. And we should all become good at dealing with this. There is absolutely no doubt about it. And for the arthroplasty surgeons here, I have to just remind them that hip fractures are extracapsular or intracapsular. And as Matt said, there are people, elderly people with significant comorbidities. And then there are these difficult ones called the subtrochanteric fractures and the complex hip fractures. And today, I will try and talk about each one of them. Now, this is an extracapsular fracture in an 80-year-old gentleman who's not entirely fit, but can walk about at his home. Is there anyone in the audience who would do a total hip replacement on this, or after Matt's talk, a hemiarthroplasty on this? That's fantastic. No one in the audience wants to do that. That's correct. You shouldn't do a total hip replacement on it. You should do the simple device called the dynamic hip screw, which just put it in the middle of the head, connect it with 3, 4, 5 screws, whichever you prefer, and the patient does well. And this patient had one on the opposite side. We gave him an exact copy of that on the left side, and he was weight bearing from day one. And we got him home in the next 4 to 5 days. That's it. Now, slightly more complex, this one. This one has got a separate trochanteric fragment and a separate lesser trochanter fragment, and slightly lower than the last one. Would you bin this head? Anybody in the audience? Or still try and fix it? Like I said, I am a fixer, and I would go and fix this. And this is what we did. We did a DHS on this patient too. And she went home, she quartered on it for about 3 years. She's 90, and she was so unhappy that we didn't do a total hip replacement or a hemiarthroplasty on her. She came back 3 years later with an intracapsular neck of femur, for which we ended up doing a hemiarthroplasty. Now, these are more complex. That is the extracapsular fracture neck of femur. These are subtrochanteric fracture. And what would you do in this? I mean, you could treat it with a total hip replacement, but God, that will be a very difficult total hip replacement where you have to cut it here, put the stem in, trochanter has to be attached back. Instead, all you do is put a big round metal thing, put a screw on the head, and this tends to do well. And that's him 2 to 3 years later, slightly medialized and slightly protruding hip, but he is fully weight bearing. He came to us with a pain in the left hip. What do you do with this? This is a broken nail, a subtrochanteric fracture that was fixed with an IM nail. And then she came to me about 6 months later with a painful hip and was referred to me with this. Would you then consider, she's 64 years old, she was an ex-social worker, smokes about 16 cigarettes a day, but otherwise a independent, lives at home. I don't do total hips in this. What I do is fix them. And what I have found is that this device, the Synthes hook plate, helps me restore the offset and the neck valgus very well. And then once I've fixed it, got the neck valgus and got it reduced, I can then slide a nail and use this as an additional fixation to make sure the trochanter is reduced on and stays on. And I've got a series of these nail plates which seem to work well. And most of them heal and they are fully weight bearing from day one. And that's 6 months later. So in about 50% of the fractures are either extracapsular or subtrochanteric according to a natural hip fracture database. And in those, binning the head is not an option. You must preserve the head. And for extracapsular fractures, I think there is only one device that we should be using. That's a DHS. And for subtrochanteric fracture, it's an air. So there you go. In 50% of the hip fractures, you should not do an arthroplasty. Let's come to intracapsular fracture neck of femurs. This is a 52-year-old lady with a minimally displaced intracapsular fracture neck of femur. The options here are either to do a total hip replacement, or if you believe Mo Bhandari's paper, a hemiarthroplasty, or in my book, I would do this. You put a DHS, you put a cannulated screw to ensure that it does not rotate. It's a derotation screw. They weight bear from day one. And that's the lateral view. And that's the X-ray at about 3 years. This lady was referred by her GP, but she was limping, but she also has got back pain. And this is what went to an arthroplasty surgeon, and he said, this lady doesn't really report any pain from her hip, and he discharged her. So in undisplaced fractures, which is definitely a certain percentage of intracapsular fracture neck of femurs, whether they are young or old, I think it is reasonable to fix them. In older people, there is a trial from Peterborough which suggests that if you fix them, the mortality rate is lower. So in very old, very frail people, I think this does have a role to play. So there you go. Now, something like this really tests you, or at least tested me. I'm sure some of you will find it very easy to do. So this is a lady who has osteogenesis imperfecta. She's 60 years old, and she presented to our trauma unit with this fracture, an intracapsular fracture neck of femur with a bent femur below it and a knee replacement put in below that. And these are the other views. Now, what are the options? So the issues in this case are, one, the neck fracture is vertical orientation of the intracapsular fracture. Not only is the fracture intracapsular, the orientation of the fracture is vertical. There is a varus malunion of the femur. The canal is narrow. And there's a knee replacement stem that stops us putting anything into the medullary cavity. And she has osteogenesis imperfecta. I will wait for the panel to tell me, but I have not seen a non-union in a patient with osteogenesis imperfecta yet. They get fractures, but they tend to all heal for some reason. So what are the options? Should we fix it? Should we replace it? Or we should do osteotomies along with fixation or replacement? So this patient actually was discussed with our arthroplasty team. And one of my colleagues is one of the nicest arthroplasty surgeons I've seen, apart from Mike Reed, who put it kindly on the World Twitter Forum of the hip surgeons. And the universal answer was to do a total hip replacement. So what he did was to template it. He put a smallest exeter, and smallest exeter was ending just below where the deformity started. And he could not put an arco stem because it was too long and it would impinge on the stem of the femoral component of the tibia. And then by then I was involved, and just because everybody was saying we should do an arthroplasty, I decided we should fix it. But apart from that, there were these issues that if you did an exeter, there was a stress razor below, so you would have to do an osteotomy and plate it. The shortest arco stem wouldn't go it. So I thought I should fix it. And this is what I do. So I put the patient on a fracture table, and I put a joystick into the head. And I manipulate it so that the position of the head, as far as I'm concerned, is perfect in the acetabulum. Then I reduce the shaft to it. and I use a guide wire, and I sometimes use an added guide wire to fix it to the acetabulum. I know children should not, younger trainees should not be doing it, but I'm very careful when you do it so I can get away with it. Then I put this screw in, and it was distracted. And as soon as I saw that, I chose a smaller screw and put the screw in, and then used a compression device to compress it. And that compressed the fracture back to where it was. And once you've done that, I put a 2-hole DHS and did an osteotomy below the 2-hole DHS. And then what you do is you change this screw plate to a longer DHS and make sure that goes well beyond the stem of the femoral component of the tibia, so that there is no stress razor. And to give it stability from front to back, I put an anterior plate. At the end of this case, I thought that we had used a lot of suction because that was the water was, but actually it was me who was pissing in my pants. And then this is her 6 months later. The medial side just take a while to fill up. That hasn't filled up, but everything else has healed. And she now wants me to fix the opposite side. So there is absolutely no doubt about the fact that arthroplasty is the holy grail. And I'm surprised as to why arthroplasty itself hasn't yet been given a Nobel Prize. It has changed the life of millions of people, but it is still has risks with it. There is a risk of dislocation, there is a risk of infection, there is periprosthetic fractures and wear, and it is a big physiological insult to the patient. Till we can do it through an MIS, until the arthroplasty becomes longest lasting without any risk of dislocation and infection, I think we should keep screwing. Sorry, I meant keep doing DHS and nailing. Thank you.
Murty, thank you very, very much for that. That was a truly amazing case, that last one you showed, and how you have the vision of working that through in advance is just so impressive. I wonder whether we could discuss the nail plate scenario though a little. I don't know. I might just ask Matt what he thinks because he doesn't mind giving you a battering, and then maybe we'll ask you to justify how that works physiologically.
It's a great case, Murty. Yeah, and you know there were definite problems with doing a total hip replacement there, so I wouldn't disagree with your approach at all there. I'll be delighted to see next year when you present the pictures with the union of the femoral osteotomy site. So being cynical, yeah, I think so. I would tend to go extra medullary here as well for two reasons, both of which Murty alluded to. One is that actually reducing the fracture is easier in my hands with an extramedullary device, and secondly, you've got to overlap with that stem in the distal femur, otherwise you will get a fracture between the two. So for both those reasons, I would use an extramedullary device in this case. The other option here, I mean, Murty put so much metal work in, you might as well have done a total femoral replacement, really. You'd probably be lighter for the patient afterwards, but that's the other option, I guess, here. But obviously that's a different skill set and so on. But no, very impressive, Murty, in all seriousness. That's a very cool case.
You know, I must come back to say as to why I did what I did. So my rationale was that one of them, if it healed, if one of either the osteotomy or the neck healed, a non-union of an osteotomy is not difficult to treat. I treat them regularly because I do a lot of osteotomies. I get non-unions of fractures and I can get them to heal. Sorry, it sounds pompous, but you can get them to heal. There are ways of getting it to heal, especially in case of femur. In absence of an arthroplasty above and below it, even in presence of infection, you can get them to heal. So non-union of an osteotomy was not a problem. And the non-union of neck with a united osteotomy, and again, is not a problem. You can do a total hip replacement. And I would send it to my colleagues who would do very good total hip replacement on them. That includes Mike. So my rationale was all I had to do was to get one of them united. And my experience with fixing neck fractures is it is almost entirely stability and alignment, almost entirely. If you can make it stable and you can get that neck shaft angle right, they heal. That's what I did in this case. I made it stable by using a DHS big screw and a small screw. And I got the neck shaft angle right by using a 135-degree plate and doing an osteotomy. And the other thing that was in the back of my mind was osteogenesis imperfecta patients tend to heal. I do not know the rationale for it. It's purely anecdotal, and we were into anecdotes before. And that's why I did that. I knew that total hip replacement was, and one of my ex-bosses used to ask me, before you do an operation, always think, what is the next operation you're going to do? Do not burn the bridges for the next operation. So that's always there in the back of my mind. If I fixed it, and if it failed, there was always an option of a total hip replacement, which is why I did what I did. And I must say I got away with it. I'm not very bothered about the osteotomy, the medial side osteotomy. It is an opening wedge osteotomy. And because it's a spiral osteotomy, it opens up a bit. That takes a long time to heal. But because everything else is healed, otherwise the screws start breaking. At 6 to 9 months, one of the screws at least breaks if your osteotomy is not healed. So none of the screws are broken, and the patient is pain-free, fully weight-bearing. I am absolutely sure that's healed. And I will bet my bottom dollar on it. Sorry.
Murty, just let me ask you a separate question about the nail plate case.
Yeah.
What's the philosophy there? Because you're essentially making it presumably very, very rigid. And
Yeah.
When I was a lad, that was considered to be a bad thing. But I mean, I know they're healing because I see them in your practice. But just explain the philosophy to us,
So,
if you would.
So two things. I mean, one of the things in proximal femoral fractures, the problem that we have is that flexion and abduction of the proximal fragment. So whether you use a nail, but if you use a nail, that the size of the nail's proximal end of the nail, and there is a biomechanical study which shows that the diameter of the proximal diameter of the nail is this one of the bigger predictors of the stability of that construct. But the nail sizes we have, it does not control that flexion. And I have seen this multiple times. You hold a clamp around that trochanter, and as soon as you remove it, even when you're fixed it proximal and distally, the proximal fragment goes into flexion and abduction. And that is a killer as far as subtrochanter fractures are concerned, as far as I'm concerned. So to control that, you use a plate to hold it together. It acts as a tension band. And as long as you keep the soft tissue envelope, the more stable you make the construct, I think bigger are the chances of healing. And now the AO is now, Bob Handley presented this talk in BOA. In fact, about 5 to 6 years ago, we were both in a Barcelona meeting, and he talked about this, what is strain modulation, where he puts interfragmentary screws in non-unions of spiral fractures of the femurs or the tibia. And he said strain modulation. That is rigidity causing increased rigidity in a load-sharing device. And this is just one step more than that. And if I am doing a nail in a subtrochanteric fracture, which is spiral, in fresh cases, in new cases, then I use interfragmentary screws around the nail to keep the fragment from flexing and abducting. And so the more stable the construct, and also when you listen to these AO trauma surgeons talking about locking plates from Austria, they will talk about what is called a fracture screw. They put interfragmentary screws, and because AO frowns upon interfragmentary screws with locking plate, they talk about fracture screws. So increasing the stability without losing the soft tissue envelope and the soft tissue, the blood supply to the fracture is good. And that has been shown in 35 cases of these nail plates that I've done, that most of them heal. There are a few failures, and that go to you, no doubt. There are 2 or 3 failures, but generally they are successful, and they can weight bear immediately. They are a very stable construct, and the trochanteric plate does not seem to bother people. And that's why I get weight bearing x-rays at about 1 year. to see whether there is pelvic tilt on the opposite side when they are single leg weight bearing. If you get a weight bearing pelvic fuse and they are single leg weight bearing on the effect side, the opposite pelvis does not tilt down. It means the abductor mechanism is working well.
Okay.
And there is no Trendelenburg weight. So I look at that, and if that is a problem, then I take the plate out. But I haven't seen it yet. Most of these people, again, are slightly older group. And I've got one patient whom I've operated upon about 6 times, not because each one has failed, because he's broken above or below it. Each time I take the plate out and he breaks below that plate, and I go and refix it. And then he goes on a motorbike and breaks it again. He came back from Wales because he didn't want it operated there, because he had broken just below the supracondylar. I had put a whole long nail and he had fallen just below the nail, so I had to do the refixation. So
Murty,
they do work.
Yeah. Sorry, Murty, we need to leave it there. The couple of the audience have made the point, which I'm not going to let you come back on, but I know you'll probably concede, is the work that's been done on the worst outcome if they've had a fixation before and then you need to go on and do a hip replacement. And Kailash has made that point, and Francisco sent a reference through from BJJ about it. So secondary THR, if you need to do it, is not as good as primary, and I'm sure you'll concede that.
Yeah.
I think we probably need to call it in. I think that's been a fantastic actual debate and generalized teasing of each other about our various practices. I've definitely learned a lot. I'm very grateful for Raman and also from the whole Ortho Hub team for inviting us to come and talk about total hip replacement for trauma and also some of the alternatives. Particular thanks then to our faculty this evening, our 3 expert faculty. So Matt Costa, to Sam Hook, and also to Murty for their fantastic talks, debate, and insights. I'd like to advertise to you the British Hip Society's meeting next week if you have an interest in this topic, and I'm sure everyone in that's listening in does. And you can tune in also to the next Ortho Hub webinar. So thanks very much, everybody. We will leave you alone, and good night. Enjoy the rest of the daylight if you have any in your country, and we'll see you soon. Good night.
Thanks, Mike.
Thanks, everyone.
Thank you. Thanks, everybody. Bye.
Bye.